Dear student, we reach now the third part, and it is about discovering what is global health equity. Global means it extends from the large scale on Earth to local when you have your 2 feet. For global health, it is any setting afflicted by preventable illness, by poverty, inequity. In other words, it is in every country. Even the rich country have their vulnerable and their poor that need intervention based on the principle of global health. Societal challenges alter the health and well-being of societies. This is something very important to understand in global health. Take, for example, the largest Native American reserve in the United States, the Navajo Nation, with its population of 300,000. Historically, almost no member of that society suffered from diabetes. Today, because there is a scarcity of nutrition grocery within the Navajo Reserve, and that they no longer eat the traditional healthy diet because cut from their culture in the past decades, and because parents often buy sugar food or food high in carbohydrates, due to these factors, 1 in 3 Navajo is diabetic or pre-diabetic. This rate is 60% higher than the general American population. This increased rate may be related to the diet that prevail in the Navajo Nation. It can be related to too little exercise or to factors in a person's genetics. But what is important to know is that overall, this is a public health issue that started when there was a change in the Navajo society after the reserve was created. What is good is that the Navajo Nation is very much aware, the leaders are very much aware of the nutritional and behavioral change needed to fight diabetes and to maintain their tradition, and became self-sufficient, especially for health. So they are struggle to reverse it. This next slide illustrates how the genetic code is key in disease you will face. But your zip code, the place where you live, your geographic code, determines your life expectancy. Using just a biological approach is not enough. And people can easily believe that we all have the opportunity to live a healthy life if we make the behavioral effort to remain healthy, regardless of where we live. However, it's not true. Life expectancy varies dramatically by location. It is where you live, and certain place is known as place where people live longer, and other places are known as place where people have a shorter life. In some cities, drastic difference, like you can see here, in New Orleans, in Louisiana, you can see that you have a difference in life expectancy from 50 years versus 80 years. You can observe that in the span of a few blocks among people who share the common urban environment. In some ways, The place people live can simply be a proxy for longevity. Understanding the drivers of such difference in longevity needs not biological analysis, but biosocial analysis. The factors involved include social classes, education, income, availability and quality of health facilities that people in your neighborhood used to go, as well as access to healthy food, good school, and affordable housing. In essence, the condition that can help keep us from getting sick in the first place. Studies have shown that the relationship between place and longevity is causal. A person of an average health who move to an area with a shorter life expectancy can expect to die earlier as a direct result. Many studies have proven that. And on the contrary, if that same person moves to an area of longer life expectancy, he or she will have a prolonged life. Those who have less money often live in certain neighborhoods or part of cities where there are often fewer groceries selling healthy food and a large presence of fast food. Future, when a family doesn't have enough money to cover all their expenses, education and health most often are sacrificed for the sake of more immediate needs such as food, eating, or water. And families are forced to make choices based on what is available to them, to the money they have. And in those neighborhoods, there is also often more insecurity and more violence. Of course, that is not to negate individual responsibility, but in low-income neighborhoods that are already resource stressed, there are real factors that impact health and wellness, such as lack of transport making the poor come late or miss medical appointments, explaining that they are more irregular in doing their clinical follow-up. There are more illiteracy that prevent the poor from reading prescription, reading expiration date on drugs, and read the name of the drugs, or even filling form in health facilities or to get advantage they are entitled to. There are not healthy housing where they can live. It's not affordable for the poor, leading to unhealthy housing with asthma, allergy, lead poisoning. They have a lack of funds to see a nurse or a doctor or to buy medicine or to pay for the lab. So low income means also no access to health or safe environment with crime. When we read the definition of the World Health Organization, the definition of health, the World Health Organization gives, health is not merely an absence of disease or infirmity, but a state of complete physical, mental, and social well-being. And you can see that the poor doesn't have that. And this definition, does it capture the personal social drivers of ill health? Does it capture the illness due to political, economic, and social forces that are driving forces behind the risk of being ill, of having a ill health? Like less transport, not access to finance, not access to quality health services. Like all these illness provoked by the factor I stated about that are embedded in the structure of the society, and we call that structural violence because it is embedded in law and in the society. There is a fundamental difference between equity and equality. And this is important to understand. Equality means treating everyone the same, rich or poor, meaning no improvement for the vulnerable because they cannot afford. While equity approach gives everyone what they need to be successful, giving more to the poor, giving a preferential option for the poor and the vulnerable. It makes sure that no one is left out of benefit, and equity can be translated, in other words, as a preferential option for the vulnerable. You will understand during your year of master why we need to study history, sociology, anthropology, among many other sciences, to have an historical and societal perspective that help you to understand the disease provoked by structural violence, for example. Let's start by talking about colonial medicine. Colonial medicine existed since the 19th century and it ended after the Second World War. Its objective was to keep colonial labor force in good shape to be exploited and to protect the health of white colonialists. It was a white supremacist medicine. It was based on race, on racial science, false racial science, because those sciences were not true. And it was meant to serve the domination of white supremacists. Colonialism did not appear naturally. It was supported, organized, and institutionalized by racial laws, which justify the support a political system where white supremacists dominate and control the other races. It was not based on reality of racial difference, but rather on a social construction of reality, meaning they justify the superiority of the white people with false science that demonstrate that Black Africans, for example, were not equal to the white people, with the latter having the white on the top and the Black on the bottom. Black also on the bottom of the access to rights. And that is not a natural distribution because we are equal. We are all human. It is a social construction created by people and states, enforced by racial laws, with bureaucratic efficiency, using the bureaucrats, organizing the separation of race and organizing the Black people as cheap labor, create policies to do that, use the army and the police to maintain that type of order, to take the land of the Black people and impose the power of the colonialists on other people. This is an example of pathology of power. It is important for global health to understand all this and to know how it happened because it impacts health. We need to understand, for example, how apartheid in South Africa was created and why people didn't stand up earlier against apartheid. We need to understand how a state creates laws operationalizing structural constructs that harm the health of a part of the population, to understand how it happened, to understand what prevention can be done when social order favor diseases. We need to understand those social constructs. For example, colonialism and apartheid had several unintended consequences, such as tuberculosis in South Africa created by apartheid. It's a good example, where men were displaced to work in mines, living and working in unhealthy conditions, where they got tuberculosis and resistant tuberculosis that prevail up to now. It is an unintended consequences because it was not the objective of the people who promote the apartheid or the colonization, because they want segregated workers, but not workers that are sick. But the system they create make the people sick and badly sick. Unintended consequences, social construction of reality, pathology of power, and structural violence are social theories that we will develop later in other session more comprehensively, but that are important to understand why it is important to understand and to learn sociology, anthropology, history, political science, and economy to understand what creates, what are the roots of disease. After colonial medicine came international medicine. This was developed during the 19th century, centered on management of epidemics between countries, and it emphasized the role of nation states. It was successful for smallpox, for example, but failed the implementation of many vertical programs such as malaria. It was criticized because it was diverting a lot of resources that could have served a problem like maternal and child health, for example. And international medicine has no concern for equity. It was also implemented during colonization. It is also a medicine of white supremacists. International medicine lead later to global health and to global health equity. Let's talk about global health. Global health has limitations. We need to understand that global health is a very new discipline and not yet a discipline. Rather, it is a collection of problems. This course is an introduction to global health and to the principal challenges of global health equity. The goal here is to understand that by analyzing this problem and using a biosocial lens to understand and solve them, we are building the field of global health. But you understand also why it is the desocializing discipline, the absence of socializing discipline, the lack of understanding of the way that social, economic, and political forces impact the distribution of both the risk of suffering as well as the tool to listen and prevent them. It is the structural violence I have explained earlier, defined as the social, political, and economic force that drive up the risk of ill health for some people in the society. This is why in global health, we use resocializing discipline, and will teach you what you need to know in anthropology, sociology, political science, economics, and others, that we will combine them with traditional medical discipline like epidemiology, demography, clinical practice, molecular biology, to build global health equity. Traditional medicine focus on the health of individuals. Public health focus on the health of populations. Linkage of clinical insight inform public health practice, and public health analysis guide the distribution of medical resources. Clinical medicine and public health must use the resocializing disciplines to address the biosocial nature of global health problems. If they want to provide appropriate services or advise on efficient policies to improve the health of population, there is a need to better understand human experience using the resocializing disciplines in combination with the biologic science. But there was not enough equity focus in the field of global health in the beginning. And this leads us to global health equity. Global health equity is a biosocial framework for analyzing complex global health challenges. It is a new interdisciplinary field that combines traditional disciplines of biomedicine and public health, epidemiology, demography, clinical practice, molecular biology, health economic, combine those with resocializing discipline, as I told you, such as anthropology, sociology, history, political economy, to understand and mitigate the disparities in health and wealth. Global health equity cannot be without strengthening health system to provide health for all, to reduce the burden of disease for the vulnerable. This cannot be done without having a broad-based social understanding. Building on our toolkits, using social theories, which is an effective and measurable tool to analyze and understand and improve the social determinant of health. The multidisciplinary component of global health equity comprise also One Health. One Health is defined as a collaborative, multisectorial, and transdisciplinary approach, working at local, regional, national, and global level, with the goal of achieving optimal health outcome by recognizing the interconnection between people, animals, and plants, and their shared environment. Ebola and COVID-19 are typical examples of this interconnection at all levels, from local, where we are all, to global, because COVID is a pandemic. And for Ebola, the disease spread to Spain and to the US. So the global connection is there. This is why one health will be taught to you through across all the courses. Global health delivery and implementation science are really connected. Global health delivery is the science to improve health system performance around the world and for all by strengthening the health system, by improving the delivery of health services. It's not necessary by creating new vaccine or new drugs, but by improving the efficiency of the health sector for the vulnerable to benefit of those progress. It does so by making the current intervention in the health sector more efficient and more equitable, taking into account the complex structural force and addressing the roots of ill health. Implementation science is the study of methods to translate knowledge of what works through research and evidence-based intervention, to translate them into policies and practice. It is our therapeutic toolkit. Implementation science is the science of the how. How can a health sector efficiently provide health services to all who need it? To be successful, you will learn principles of management, leadership, and system design. The biosocial framework using traditional biomedicine, public health discipline, and resocialized discipline as social tool theory are the diagnostic toolkit that we need to understand the complexity of global health problem. This understanding will link to the set of intervention to be implemented after we understood and found the solution. And this brings us to the right part of this slide. To effectively address the challenges and solve the global health problem, we will use the therapeutic toolkit, leveraging leadership and strategic thinking skills to implement innovations. This slide summarizes the year you will spend in your master program, the year we will spend together. Because you are all future leaders in global health, a quarter of the program will be a mini MBA, and you will be introduced to key management practice, framework for strategy decision making, and essential leadership and management skill. You will also be equipped in the skills to design and implement effective health program and to use leadership and strategic thinking skills that can define problems and the set of priorities we need to tackle for improvement. As shown earlier, you will need public health epidemiology and demography. So a quarter of your training will be a mini master in public health, a mini MPH. You will also have the principle of global health that comprehensively explores historical, political, scientific, and practical approach to existing and emerging global health problems. Finally, you will get a deeper understanding of the diagnostic and therapeutic toolkits. The rest will be the practicum with immersion in the field. With this information, the question is, how do we forge a new discipline of health equity? This will be done with and through new investment in research and training. both of which are pillars of a university mission. This will help demonstrate the basic principle as well as build and reorganize institutions. Research and training need to be linked to the delivery of health. For ethical reason, we cannot have health research without health service delivery. Therefore, the answer to the question, how do we forge a new discipline of global health equity? The answer to that comprises the need to integrate research, education, and services. An important thing before ending the course is to build a common vocabulary for everything we have explored in those 3 sections of this first course. And it is biosocial approaches, social determinants of health, the 4 H's of health system that can be 5 if we add support, structural violence, global health equity, global health delivery, implementation science, and the difference between equity and equality. You need to understand all those concepts and use them accurately. You need to know them well, know well what they mean, to correctly express the concept you have in mind in our future discussion. Dear student, we have reached the end of this course. Next, you will continue during all the year with a real focus on details, with more in-depth discussion on social theories and through case studies. I thank you.